As a land-grant institution, we would like first to acknowledge the Tongva peoples as the traditional land caretakers of Tovangar, that is the Los Angeles Basin and South Channel Islands. Hello and welcome. Thank you for joining us for the California Health Interview Survey 2020 data release. As the nation's largest state health survey, the California Health Interview Survey, also known as CHIS, provides actionable data on the health of and healthcare for California's residents and is used by legislators, policymakers, local health departments, state agencies, community organizations, advocacy groups, foundations, researchers, and more to make informed decisions and compelling arguments, and ultimately to improve public health. 2020 was an unprecedented year for public health and for the world. We experienced a global pandemic which took the lives of far too many and further exposed the deep fractures that we have in our society. We saw racial inequality worsen, an economic slowdown, and a presidential election that divided us even further. As the US continues to grapple with the pandemic's toll on countless lives, findings from the 2020 CHIS takes a closer look at statewide impacts among California's 39.5 million people. Perhaps most notably, and for the first time in our survey's history, we began releasing early data from our 2020 survey last fall to meet the urgent need for data on the catastrophic COVID-19 pandemic. We adapted the survey to ask questions on personal and financial impacts, views on getting the vaccine, and following safety protocols. So today's presentation will cover the data we obtained regarding the pandemic's impact, as well as how other events in 2020 may have impacted Californians' health. For example, how was healthcare access impacted during this time? What were the effects on residents' mental health? Did Californians adopt healthy behaviors, or did they have worsening behaviors due to being at home more often? My esteemed colleague and our CHIS director, Todd Hughes, will walk through our 2020 survey methods and key findings. And Senior Public Administration Analyst Sean Tan, new member of the team, will share findings from a policy brief that dives deeper into how we surprisingly reach a milestone in health insurance coverage, although disparities in access across various groups remained. As always, today's slides are available on our website, or they can be requested from our communications department at the email address shown on your screen. Please note that we have some members of the CHIS team monitoring and responding to online questions. So do post things in chat. And we will reserve the last 15 minutes of the seminar for the Q&A, and we do encourage you to ask questions through the presentation as well as the Q&A function in Zoom. Before we begin our presentation, I'd like to share a couple of upcoming events. On October 4th and 5th, we will host our annual E.R. Brown Symposium in honor of UCLA Center for Health Policy research founder E. Richard "Rick" Brown, who spent his life advocating strongly for a healthcare for all system that would ensure health services for every Californian. This year's virtual symposium, Opening Doors for All, Improving Health in Housing and Homelessness, will bring together public health leaders, community advocates, policymakers, and other leaders in the fight to end homelessness to help identify past successes and lessons learned. We do this so that California can invest effectively with evidence-based solutions to create a healthier, more prosperous California for all. We also have another upcoming event. On October 8th, we will present a workshop on imputation strategies for racial ethnic data disaggregation as part of our national network of health surveys addressing health equity through data disaggregation workshop series. So information is there, and links to both of these events will be posted in chat. The event that's upcoming will feature Mark Elliott, a senior principal researcher and distinguished chair in statistics from the RAND Corporation. So now, for our community of evergreen supporters, thank you. You may recall that we've been releasing the latest annual CHIS data around Halloween of each year. Now, for the first time, September 22nd, we are releasing more than a month earlier than we've done in the past. Our team made this so despite lots of uncertainties that we experienced last year. Within a couple of weeks of starting 2020 CHIS data collection in early March, California was the first state to issue mandatory statewide stay-at-home orders, if you all can recall that. Consequently, the initial challenges we faced as a survey were questions of program viability. Could we continue, to print and mail our survey invitations? Will the telephone interviewers be able to work remotely? Could we implement a secure remote access for UCLA CHIS staff to process data? Prior to the pandemic, all of our statisticians handling CHIS data had to stay in one locked up room, here at the UCLA Center for Health Policy Research, and could never work remotely. And most importantly, will respondents participate, during this pandemic? And the answer is yes, yes to all. With an earlier release and additional products of preliminary estimates or dashboards, our full story is forthcoming in the American Journal of Public Health. So here are our new dashboards. I said, in addition to our ability to continue with data collection in 2020, we also introduced new products. And these new products were in getting the data out as quickly as possible. And some of it was data that we've collected in the past. So our new dashboards included both preliminary monthly estimates, and we've never done same year release of preliminary estimates. And we started to do that last year, and we continue to do that this year as we're collecting CHIS 2021. We also provided a dashboard of COVID-19 rates and risk factors based on earlier CHIS data, but linked to the daily data that we were getting from the state and from the different counties. And then we also looked at risk factors by California county data tables, and also launched a Native Hawaiian Pacific Islander COVID-19 data policy lab dashboard that looked at not just California, but across all the states in the United States, and featuring the case and death rates of due to COVID-19 for the Native Hawaiian Pacific Islander population, which is often overlooked in the presentation of statistics. What is CHIS? So in continuing to create value, we strive to be nimble despite being the nation's largest state health survey. And as noted, the survey has depicted the health and well-being of Californians since 2001. This actually was my very first job in coming to UCLA. And the 2020 survey covers a broad range of topics about Californians and health, including medical conditions, access to healthcare, mental health, health status, and health behaviors, which can be viewed across a range of sociodemographic factors. So CHIS, in my mind, is a public good. It's a tool to assess the needs of Californians at the state and local levels, providing population data for research insights, service and program planning strategies, and informing advocates and policymakers on what needs to be done to improve and promote the health and well-being of the population in our great state. We are fortunate to have partners and sponsors from federal and state health agencies, foundations in California, nationwide, and many others. And so I thank you, our partners and supporters for CHIS. How is CHIS done? CHIS collects data both through a self-administered web survey, as well as if you prefer to take the survey by phone with a telephone interview. And we collect data on a randomly sampled adult and a randomly sampled child, if the child is present in a household, as well as a randomly sampled adolescent, if an adolescent is present. The adult is the one that provides information on the child, but provides permission for us to contact and get information from the sampled adolescent. To reduce what's called coverage bias in survey speak, that is that a survey may selectively exclude segments of a population because of its design, such as, say, an English-only survey. CHIS is conducted in many languages, in English, Spanish, Cantonese, Mandarin, Korean, Vietnamese, and Tagalog. So here's our 2020 data collection results. And you'll see that we interviewed over 21,000 Californians in 2020. And this is the racial, ethnic breakdown tabulation by the major Office of Management and Budget categories of race, ethnicity. There, you can get at subgroup data for some estimates because CHIS does go beyond asking these major OMB categories and go more into specific subgroups for the Latino, Latinx population, the Native Hawaiian, Pacific Islander population, the Asian population, and we also get at tribal affiliation for the American Indian, Alaska Native population. So I'm going to hand it over to Todd to talk about the innovations of CHIS. But I just wanted to note that one particular one was that in 2020, that we continue to increase the child and adolescent interviews. That had been a challenge for us in the previous years. And a lot of this was because of the redesign and innovations that Todd and his team led in 2019 and consequently in the 2020 stay-at-home order. So Todd, I'm going to hand it over to you.
Thank you, Ninaz. Yeah, so the 2019 iteration of the California Health Interview Survey began the 2-year cycle where we implemented a redesign to the study based on experimentation that was conducted in 2018. Some of those changes yielded benefits across multiple aspects of the program. And on this slide, we can demonstrate how it really helped to turn the tides on some of our declining rates of interviews for children in the household, as well as the interviews that we conducted with adolescents aged 12 to 17 within each household. 2019 showed a marked increase, and 2020 demonstrated ongoing increases in those rates of interviewing. This is due to the methodological innovations that we implemented, but it's also due, admittedly, to the stay-at-home orders that led to parents and children being at home more together and perhaps being more willing to participate in a health-related study. So what was it that we implemented in 2019 and 2020 for our data collection? Well, we revised our sample design from a random digit dial, telephone-only administration of the survey to an address-based sampling design that started that had 2 different phases of data collection. The first was a series of mailings. Up to 4 mailings were sent to each selected address with an invitation for them to, for the selected sample adult to go online and participate by the survey electronically. Alternatively, they also had the option to call a toll-free number to complete the survey by phone. After these repeated mailings and multiple attempts, we then transitioned to follow up with those who had not yet responded to the survey using telephone non-response follow-up. So call center staff made up to 6 dial attempts to each of the selected households. Implementing these changes in 2019 was quite fortunate for us. Number one, it helped to enable us to be able to go into production despite stay-at-home orders in 2020 without major disruption. It also allowed us to be able to measure the changes from the redesign itself in 2019 versus additional changes that happened as a result of the pandemic. And to help us understand these changes, we have produced and released an updated report today that helps to measure trends across the years through 2019 and through 2020. And it looks at these changes in numerous different key indicators for the survey. And then we can explore whether those are actual changes due to changes in the population over time. It can help inform whether these are due to sample composition changes and sampling frame and mode changes, or whether there may be some potential measurement differences due to telephone versus an internet version of the questionnaire. So this helps to elucidate some of those findings. And based on these evaluations, we feel assured that data users will be able to trend most variables, but we do share the word of caution that if you're noticing something unusual, especially between 2018 and 2019, to interpret those trends with caution due to our redesign. And we'd like to thank Brian Wells and Zhengzhou Fu, who worked so hard in this report. Additionally, for our more technical audience members today, we did implement some enhancements to the weighting that we applied to the 2020 survey that we also retroactively have applied to the 2019 CHIS data as well. For 2020, we began by separating out the South Asian not Hispanic group from the other Asian not Hispanic group in our weighting process to ensure that we better reflected the proportions of the state population in these groups. Additionally, we made other improvements to child sampling and jackknife replicate weighting mechanisms as well. And then as we considered whether or not to apply those changes retroactively to the 2019 CHIS data, we also learned of a revised set of 2019 population estimates from the California Department of Finance. And that had significant impacts on counts for American Indian, Alaska Native groups, Native Hawaiian and Pacific Islanders, as well as multi-race groups. And so we did decide to revise the weighting of the previously released 2019 CHIS data and have reissued the 2019 CHIS data today with new public use files as well as updated data in the Ask CHIS dissemination platform. The report that I mentioned on the previous slide does include both the old 2019 and the new 2019 estimates to help further explain the impact of these changes or demonstrate its impact to our data users. So we encourage you to review that report. All right, and now it's our pleasure to share with you some highlights produced from the 2020 CHIS. More than 1,000 different survey variables are being released today in our public use files, and over 300 different survey questions or topics are now available to explore in the Ask CHIS platform. It's impossible to discuss more than a small subset of these findings today, but we've selected a small set of topics and items that we feel provide insights that are most relevant to the challenges California faced in 2020. In the 2020 CHIS, we asked adults a number of questions related to the coronavirus pandemic, including questions on whether they ever had or thought they had had COVID-19, whether they would plan to receive a COVID-19 vaccine if and when one becomes available to them, and whether they continued to report to work during the stay-at-home orders because they were an essential worker. Looking at the data for these questions, we observed a higher rate among essential workers of those who ever had or thought they had COVID-19, 15.1% versus 12.1% for other adults. Somewhat surprisingly, though, we saw that these essential workers were somewhat less willing than other adults to plan to receive the vaccine when one becomes available, 73.6% versus 76.7%. The next slide highlights some ways that CHIS data reflect changes regarding smoking and tobacco-related issues during 2020, and may have been influenced by reductions in social contact during the pandemic. As you might expect, with many people staying home or working remotely, the percentage of adults reporting exposure in the previous 2 weeks to secondhand smoke from tobacco products or e-cigarette vapor dropped significantly in 2020 to 26.6%. That is basically half of the rate from 2018 and a significant drop from 2019 as well. We also observed statistically significant reductions in the rates of flavored tobacco use in the past 30 days for adults, dropping from 5.8% in 2019 to 4% in 2020. And adult e-cigarette use in the past 30 days also dropped from 4% in 2019 to 2.8% in 2020. In 2020, we all understood that the stay-at-home orders were likely to have significant impacts on youth in California. The CHIS captured several changes in health-related behaviors for adolescents, some of which were positive and some were less positive. First, focusing on some healthy changes, we observed a significant reduction in binge drinking during the past month for adolescents aged 12 to 17, which dropped from 7% in 2019 to 2.6% in 2020. With more time at home last year, we also identified a significant increase in adolescents reporting that they were eating 5 or more servings of fruit and vegetables each day, which rose from 26.1% in 2019 to 33.3% in 2020. Unfortunately, though, not all of the behavioral changes for young people were healthy changes during 2020 stay-at-home orders, and this included changes to physical activity and internet use. The CHIS asks about the amount of time children and adolescents aged 2 through 17 spend on typical weekend days participating in sedentary activities, such as sitting and watching TV, playing computer games, or talking to friends. We observed a significant increase in the amount of weekend sedentary time in 2020. 40.8% of youth reported spending 5 or more hours per day in 2020 versus 35.4% in 2019. Among adolescents aged 12 through 17, we also identified more than a 50% increase in 2020 for those who reported being on the internet almost constantly each day. That figure rose from 28.6% in 2019 up to 43.2% in 2020. In the 2020 CHIS, we also asked adults whether they had experienced any unfair treatment because of their race or ethnicity. Overall, 1.9% of adults reported this. But as you might expect, given increases in hate incidents reported among Asians during the pandemic, and the racial injustice protests that occurred after the killing of George Floyd in May 2020, the rates of unfair treatment were not equal for all race groups. Specifically, Black adults reported the highest rates of unfair treatment due to race in 2020 at 6.4%, followed by Asian adults at 4.2%. White adults had the lowest rate reported of unfair treatment, followed by Latino and 2 or more races. Unfortunately, we did not have sufficient sample sizes or data to release stable estimates for American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. Next, we consider the mental health impacts of those that experience this unfair treatment due to their race or ethnicity. Rates of those that had ever seriously thought about suicide and rates of those experiencing serious psychological distress in the past year were both significantly higher for those adults who reported being treated unfairly because of their race or ethnicity. 19.3% of those who reported unfair treatment due to race or ethnicity had experienced suicidal thoughts, compared to 12.1% of adults that had not experienced unfair treatment. Similarly, 18.5% of adults experiencing unfair treatment due to race or ethnicity experienced serious psychological distress in the past year, compared to 12.1% of other adults. The 2020 questionnaire for CHIS included a question about whether the respondent experienced an increase in interpersonal conflict in the household during the pandemic. We compared these responses to other survey questions that captured the economic impact of the pandemic. Specifically, whether the household had difficulty paying for basic necessities, such as paying tuition, bills, or affording groceries, as well as whether the respondent reported losing a job during the pandemic. We observed statistically significant higher rates of interpersonal conflict within those households that had experienced these significant economic challenges. 22.9% of households reporting difficulty paying for basic necessities during the pandemic also reported an increase in interpersonal conflict, almost twice the rate of those households that had no difficulty paying for their basic necessities. Similarly, 19.3% of households where the adult respondent lost a job during the pandemic experienced increases in interpersonal conflict, compared to 13.9% of households where the surveyed adult did not lose a job. The CHIS asks a series of questions to adults about their participation in different types of elections, including national or presidential elections, state elections, and local elections. The data presented on this slide show a composite measure which reflects whether a respondent is always engaged, meaning always votes in all types of elections, frequently engaged, which means always votes in some types of elections, sometimes engaged, meaning sometimes votes in some types of elections, or never engaged, meaning they never vote in any type of election. So comparing the 2020 results to 2019, we observed that 1.4 million more adults in California met the criteria for being classified as always engaged in 2020, increasing the percentage of always engaged adults from 46.2% in 2019 to 51.3% in 2020. All of the estimates for the less engaged groups showed declines in 2020, including the frequently, sometimes, and never engaged groups. On this next slide, we look more closely at those who were classified as always engaged voters. When comparing the 2019 and 2020 rates by race and ethnicity, we see increases in voter engagement across most of the race groups, including Latino, White, Black or African American, American Indian, or Alaska Native, and Asian groups. According to the 2020 CHIS, the highest voter engagement rates were found among American Indian and Alaska Natives at 68%, next among whites at 61.2%, and then among Blacks or African Americans at 56.5%. So I know that was just a taste of the many topics and questions and new data that were released today from CHIS 2020. The CHIS methods and questionnaire content does evolve each cycle to address emerging topics that are important to our stakeholders and funders and to the California population at large. The What's New document posted at the link here highlights all of the changes in our 2019 to 2020 design, as well as in our survey topics. The 2020 CHIS included new questions on the impacts of the COVID-19 pandemic that we've highlighted today, plus others. It also included new adult questions on Planned Parenthood utilization and adolescent attitudes towards voting. New data on these questions and the many other questions on the survey can be accessed using the data dissemination tools that Ninez will be describing in a moment. But first, it is my pleasure to introduce our colleague Sean Tan, who will be sharing some highlights from a new policy brief released today, which uses CHIS 2020 data to better understand impacts of the pandemic on health coverage and access to care. Sean is a senior public administration analyst on the CHIS team here at the Center for Health Policy Research. Sean.
Thank you, Todd, and hello, everybody. Thank you for being here today. During this presentation, we will be looking at access to care in 2020 amidst the COVID-19 pandemic. But before that, I would like to acknowledge the support of the California Healthcare Foundation, of the California Health Interview Survey, and this policy brief. The content of this policy brief is solely the responsibility of the author and does not necessarily represent the views of the California Healthcare Foundation. For more information about this brief, please see the full content and accompanying appendix, as well as infographic on our website. As research literature suggests, healthcare coverage is an important factor in accessing care, especially in the United States where health insurance is not provided universally. In 2020, we found that 94% of people in California had health insurance. This is a profound finding in two ways. One being that this is the highest rate of people who had health insurance in the state since CHIS began surveying Californians about their health care coverage in 2001. Secondly, this indicates that there is a window of opportunity for the state to achieve universal health care coverage or ensuring that all Californians have health insurance. Despite this achievement, equitable access to care remained a challenge for many Californians in 2020 due to a variety of factors, including the COVID-19 pandemic. In determining the status of healthcare access in California, we looked at a variety of indicators associated with access to care, including whether Californians had a usual source of care when they were sick or needed health advice. We found that most Californians had a usual place to go when they were sick or needed health advice. However, the proportion of Black or African American Californians who reported having a usual source of care decreased from 91.9% to 89% between 2019 and 2020. More than 1 in 10 Black or African American Californians reported not having a usual source of care, despite 88.2% having health insurance. Among Black or African American Californians who reported not having a usual place to go for care, 26% were children, 66.8% were adults, and 3.7% were older adults, meaning they were 65 years or older. This is particularly concerning because COVID-19 disproportionately affected people of color in 2020. Specifically, Black or African Americans had a higher risk for COVID-19 infection, hospitalization, and deaths when compared to white individuals in the United States, according to the CDC. Next slide, please. We also look into how visits to the doctor's office and preventative visits or routine checkups were affected during the COVID-19 pandemic in 2020 as a means to evaluate access to care. We found that 67.9% of California adults had a preventative visit in 2020, which was significantly lower in 2019 when 71.1% of California adults reported having a preventive visit, and by far the lowest estimate since 2013. Similarly, the proportion of adults who reported having visited a doctor's office dropped from 82.4% in 2019 to 80.3% in 2020. Next slide. While preventive visits and doctor visits decreased significantly, we found that 13.8% of Californians had delayed or did not get the care they felt they needed in the past 12 months in 2020. We also found that lower proportions of Latinx and Black or African American populations in California had delayed care when comparing estimates from 2019 and 2020. On the other hand, the Asian American population reported the greatest increase in delaying care in terms of percentages across any racial or ethnic group between 2019 and 2020. Of those who delayed care, more than 59.5% had forgone care or had not eventually gotten the medical care they felt they needed in 2020. In examining the effects of COVID-19 on access to care, we found that more than 1 in 5 or 21.6% of Californians had not gotten medical care in 2020 due to the COVID-19 pandemic. Exploring the data further, we found that 20% of children had forgone care due to COVID-19 concerns, and 17.9% of adults also reported forgoing care due to COVID-19. Older adults, or those who are 65 years and older, were nearly 2.5 times more likely than adults to forgo care due to COVID-19, with 44.2% having reported that they did not get medical care due to COVID-19. Next slide. Aside from COVID-19, the cost of medical care or lack insurance was a major barrier to accessing care. 28% of white individuals cited COVID-19 as a reason for foregoing care in 2020. Similar proportions of white, or 28.1%, reported cost of medical care or lack of insurance as a barrier to accessing care. Similarly, 31.9% of Black or African Americans and 30% of Asian Americans reported that the cost of medical care or lack of insurance acted as a barrier for them in accessing care. 40% of Latinos in California had cited cost of care or lack of insurance as a barrier to care. I'm gonna give it back to Todd or Nines.
Thank you. Thanks so much, Sean. So getting involved with people actually also just pinging me about the data. So I'm going to briefly talk about how to access CHIS data. And we say here almost every day that the purpose is for data not to sit on the shelf, but to democratize that data. And we do this, though, with real profound commitment in protecting the confidentiality of all the Californians who have taken time to share what they're going through in terms of health access, also in terms of what we call social determinants of health, any barriers that they're facing in terms of like food insecurity, access to green space, for example. So we do go through this process of disclosure risk mitigation review, ranking and putting items that may be highly sensitive or respondent may be highly identifiable through our data. So we go through that. We do democratize it, and I'm going to talk about some of the tools and vehicles that we do that. And we do try to reach a large and diverse audience across the divides of technology, of skills and resources. And here's how we do it. If you are a researcher and you want to run, the data through your own statistical program, R, Stata, SAS, SPSS, you can access the data through the Data Access Center if it has confidential data, or if, say, you wanted to link geocoded data because the geocodes are not going to be available in public use files, or if you wanted to access some elements of the survey that are highly sensitive and we don't put out in our public use files. What's commonly used by researchers and loads of publications, I'm sorry, every time I speak, people are pinging me, but there's loads of publications that use the public use files. And these are freely available. If you wanted just the 1-year files, like right now, at the moment, you can go to our web address and download it without any transaction fee or time. If you wanted the 2-year file, though, we do ask you to register so that we know what you're doing with the 2-year file, and we want to make sure that you're not trying to link anything from the 1-year to the 2-year file that might risk disclosure for our respondents. If you don't like to use statistical software, we have Ask CHIS. And Ask CHIS is award-winning. We've been an all-star since 2013. It's an online health data query tool. You just Google Ask CHIS. You might get Ask CHIS NE though before, but just make sure that Ask CHIS without the NE. Ask CHIS is you can do crosstabs, you can limit the population, you can look at sub-state level estimates, for example, at the county or the county groups, which I'll go to in another map as we continue. Ask CHIS Neighborhood Edition is the little sister of Ask CHIS, although it's a mighty little sister. It is also available in Spanish, so Ask CHIS NE en Español. It's granular health data beyond counties, and it's not direct estimates because it'd be a massive survey, almost be a census if we got to the zip code or census tract level, but the estimates are generated through a process called small area estimates. And it's not the 200, 300 plus variables that we have in AskCHIS. It's about 20 CHIS variables. And then we also put in some other non-CHIS variables from the American Community Survey, from CalEnviron screening, for example. And most recently, we started putting these indices, like the Healthy Places Index, that get at vulnerabilities of place, social vulnerability index, area deprivation index, for example. And then say you don't even want to go to a computer, or you don't want to manipulate or use a web query system. We actually have pre-digested health profiles that are PDF files, and you can download it. And this came about where an advocate said, Inez, I just want something where I can print it out, have a piece of paper, go to city council and show these stats. And so we made that available too. Of course, like me, when I go through new applications, I need to see how it's done, and YouTube is like the go-to place. But here we also have some YouTube health data short tutorials on how to use these tools so that it's on demand, you can use it. If you also want more, like say a community organization wants to have a fuller tutorial, we have webinars that are available through our health data program. So next time, please. Next slide. So the CHIS has 56 geographically defined strata. And one of the reasons why CHIS came about was Rick Brown, our founder, mentor, wanted to ensure that we have data that is available at local levels. A lot of the federal data sets would just give you a state level, but not so much as a sub-state level. So we have 56 defined strata. And for those of you from California, we have 58 counties, but there are some very small counties. And so we had to group these counties. So there's 3 county groupings, and we show this here. We have the up north, counties that are grouped together: Del Norte, Siskiyou, Lassen, Trinity, Modoc, Plumas, Sierra, and then the 3 ones in the middle, Tehama, Glen, Colusa, and then towards the Nevada border, Tuolumne, Calaveras, Amador, Inyo, Mariposa, Mono, and the smallest county of all, Alpine. Next slide, please. Plus we also have lower geographies. So for LA, thank you, thanks Todd, we have 8 service planning areas. So we can produce estimates for those 8 service planning areas, or SPAs. And for San Diego, thank you San Diego for all your support, we also can produce 6 health regions. If you wanted lower levels, like for example, if Mono County wanted their estimates and not part of that larger group, we can also pull several years of data to generate estimates for the smaller groups, smaller county groups. Next slide, please. So now it's 2020 data is live. Some of you have already looked in AskCHIS. It's live, it's there. And so for AskCHIS, one of the web query system, you can get state level data. And as I had explained, also counties. You can have county level data or county groups. AskCHIS Neighborhood Edition, the little sister, the mighty little sister, you can get at assembly level, Senate level, congressional level, as well as cities and zip codes. And thank you to UCLA Fielding School of Public Health through an innovation grant, we're also now able to present the data at the census tract level. So this is now available. It's not available every year as just Neighborhood Edition. We need to accumulate at least 2 years of data to generate the small area estimates. So the 2019-2020 data for the small area estimates for AskCHIS Neighborhood Edition will be coming in mid-2022. Just a visual on looking at the census tracts. I know most of us don't know what census tract where we live in. So there is an address lookup tool where you would type in your address and then you would get the census tract. And then what our statisticians have done is making sure, because there isn't quite an exact overlay of tracts with zip codes, although there's something called zip code tabulation areas, but we do ensure that there's a harmonization so that say your county level estimates from Ask CHIS Neighborhood Edition is going to match the county level estimates from if that you got from Ask CHIS. So I just wanted to again thank all the brains behind that operation. And next slide. And we have this on-demand learning center that I had mentioned. There's free tutorials on using Ask CHIS and Ask CHIS Neighborhood Edition. There's tutorials are 10 minutes. Sorry, we haven't gotten it to 1 minute, so we can post on Instagram, but it's 10-minute segments. It's simple, understandable. And we also have a data access center. So should you need any more help that we have, you can go to our data access gurus on how to get more help. Next slide. So we do invite you to visit us at chis.ucla.edu. Wanted to give a shout out to our data collection partner, if you're here in our Zoom room, SSRS, our content partner, the Public Health Institute. Thank you for, you've been with us since the beginning of CHIS. The members of our advisory board and our committees and the rest of the UCLA Center for Health Policy Research CHIS team, and their names are here, but they're also in the room, probably answering a lot of the questions. And I wanted to wholeheartedly thank you, but in special thanks to the director of CHIS, Todd Hughes, who inspires in a very efficient way so that we can get our product out as soon as possible into your hands. So thank you very much. And with that, I think, Tiffany, I think we can start our Q&A.
Great, thank you so much. Good afternoon, everyone, and thank you for joining us for the CHIS 2020 data release. My name is Tiffany Lopes, and I'm the Director of Communications here at the Center, and I'll be going through the audience questions. So if you have questions, please feel free to use the Q&A function in Zoom to continue asking them. So let's get started. Does CHIS collect information about social determinants of health? And can you provide a few examples of those variables?
I'm happy to start. Sorry, my cat just arrived, so apologies for Q&A. Well, so we have questions. So social determinants of health are the conditions where a person lives, works, plays, and prays. It's the opportunities that are available for people to have the healthiest life possible. So not necessarily just within what's provided within the clinic walls. And so some of those social determinants of health, include, disability status, race, ethnicity. I believe is social determinant of health. I've certainly been in some circles where it's separate from social determinants of health. Sexual orientation and gender identity. We were one of the first large surveys that included questions on gender identity. We have questions, of course, on income, on educational attainment, and occupation. So we have, I know some researchers here are just so happy that there was a time we didn't have occupation for many years, but we have occupation in industry, and absolutely so important right now, particularly in the divisions of who were essential workers, who were not, who got to stay at home with the privilege of staying at home. Very important. So we do have that. We have questions, not every year, but we do have questions on unfair treatment, so on discrimination. And we have questions on access to foods, to healthy foods. And we also have some questions on, as I think I mentioned, say, access to green space, because the environment and the opportunities for walking, the opportunities for leading a healthier life, it's not so much necessarily a behavioral choice, but a constraint that's imposed by the environment and the politics behind the environment. So I hope that's enough. Yes, my cat has questions. Anyone else? I'm sure I missed everything because we've just, civic engagement, social capital, social isolation, particularly for those who are 65 and older. And the social capital questions are questions like, do you feel you could get help from your neighbors? Do you trust your neighbors? So all of these have been linked, through the Project of Human Development in Chicago neighborhoods on looking at like how the extent of that there could be associated with violence in a community, to the extent of where there's information networks and support that can help people understand where resources are.
Thank
So
you.
I could talk about social determinants the whole day, but yes.
Very, very thorough answer. Speaking about older adults, is it possible to disaggregate the age data even further to get a picture of just older adults?
Or maybe I'll take this one, Inez.
Yeah.
So
Well,
one of the powerful features of the Ask CHIS platform is that you can look at any of the variables that we presented, you can cross it by other key variables that might be related, and you can filter the data by many variables as well. So age is certainly one of those variables that you can filter quite easily in the Ask CHIS system. Set your filter for 65 and over, and then all the data results that you'll see displayed reflect the needs of older population.
Thank you, Todd. Someone asks if you can, it seems like so many data points could be impacted by the change to the online survey. Is this something you can speak to?
Sure. The report that I described earlier by Brian Wells and Zhengzhou Hu actually found that the impact of our transition to a web administration was less than you might expect from as far as any adverse impacts on trending of data. There are certainly some questions where we had to modify the presentation of the question for use in a visual context versus an oral context by telephone. And there are a few of those variables that we identify in the report where you should not consider trending across the redesign without caution. So we do encourage you to consider very carefully how you trend before and after. So for example, hypertension is a variable that in the telephone mode, we didn't specifically say, we didn't ask whether you were borderline hypertensive, but if they offered verbally that they were borderline hypertensive, we captured that. In the transition to the web survey, we explicitly added the category for borderline hypertensive. And so it actually, increased the reported rate of borderline hypertensive because it was presented as a visual stimulus. So that's one example, but I encourage you to look at the report for more details on other variables too.
Thank you, Todd. So somebody asked a question, for a layperson, how is accessing data on Ask CHIS Neighborhood Edition different from seeking DAC access for geocoded data?
So I can answer this, as I talked about that. If you just wanted estimates of, say, your Koreatown, or the Mission in San Francisco, that you could just get those estimates, say, of food insecurity or of uninsured rates. You can get that through Ask CHIS Neighborhood Edition. But say you wanted to link record level data. So say you wanted to link, individual CHIS data with these neighborhood or community level variables, then you'd have to, once you get into linking it with the record level data, then you'd have to go through DAC access. So you would have to go through, I think, Andrew Yunke, who has also been very active in chat. Thank you, Andrew. So that's one example of why you would you could just well another example though is, say you had your own data set, not CHIS, but you wanted some some zip code or census tract level data. You can actually just then download the Ask CHIS Neighborhood Edition data and link it directly to your data set. So that's also another way of using CHIS.
Thank you, Inez. We have a bunch of questions about data disaggregation. So one of the things is, can you talk a little bit about how Asian groups are disaggregated? And then I know that there was a question in the chat about individuals from the Middle East and how we're going to be disaggregating that data in 2021.
I started that conversation, but I'm hoping Todd can explain what we did this year in 2021. The chat I put was that the individual would choose, if they're from the Middle East, it's up to them to choose whether they choose white or black, whether they choose Latino or non-Latino. And then based on that choice, then the tabulation is based on that choice. But we do understand that there was a national content test in the census of putting the Middle East, North African population as a possible separate category. But I'm going to now hand it over to Todd on, since Todd used to work for the census and the American Community Survey.
Right. So we actually, CHIS has decided in 2021 to follow the lead of the 2020 census in the presentation of both white and Black race responses that allow for an open-ended write-in response for the respondent's origin within that race. So specifically for the Middle Eastern North African group, what we're doing is for 2021, we're starting to look at those written in coded responses, code them and classify them to various larger groups, and then we'll be able to identify those who identify as MENA from within those write-in responses. So it is perhaps not as clean as having a separate MENA checkbox for them to check, but we decided to follow the standard set by the 2020 census in that regard. So stay tuned next year when we'll be able to release the 2021 CHIS data with some enhanced data for this.
Great plug. I'm going to turn it over to Sean. We have a couple questions for Sean. Do you know the demographic makeup of those who continue to be uninsured? And then is there any data on migrant status and health insurance?
That's a great question. From what we know from CHIS 2020, there's about 2.3 million individuals who are uninsured in California. And in terms of demographic data, AskCHIS is a great resource in terms of trying to create the estimates. But from what I know, there is about 64% of those who are uninsured are Latinx, and about 20% identify as white. I also, in my policy brief, cited a particular study in terms of who will remain uninsured and is projected to be uninsured up to 2022. And what they found is that most of those individuals are individuals who are ineligible to obtain health insurance due to their citizenship or immigration status.
Thank you. Can you speak to, and I think this is going to be for Todd or Inez, can you speak to the impact on the data results of what part of the year the data were collected, for example, either early in 2020 versus fall of 2020?
Sure, I'm happy to do that. And I'm also happy to speak to one other question in the Q&A that I said I'd be happy to answer live, but my answer then moved it to the answered category. So apologies for the user error on that one. But so as far as the timeline of when we collected 2020 CHIS data, the bulk of the survey interviewing occurred between March and September, with a little bit carrying over for adults through October, and then teen adolescent data collection wrapping up in the month of November. So it all essentially occurred, in the world of the pandemic. It was just a week or so before the stay-at-home orders were implemented in 2020. The other question I wanted to respond briefly to was by a user who asked, what did CHIS do right in data collection during the pandemic lockdown that helped avoid the data quality issues that were seen in the 2020 American Community Survey? So given my past history at the American Community Survey, my heart certainly goes out to that team and all the hardworking folks at Census who produce data that we all rely on so extensively. But the specific issue that really was different for CHIS versus the American Community Survey is data collection centers for the American Community Survey are primarily focused with their mailing operations and their telephone operations at a call center in Jeffersonville, Indiana. And during their stay-at-home orders, that whole center had to shut down. So they lost essentially their ability to collect telephone data, as well as to mail out invitations to respond to a paper questionnaire or online. The CHIS survey operations, our primary mailing operations were based out of Pennsylvania, where printing and fulfillment services were deemed to be essential activities, and so they continued throughout the pandemic without interruption. Additionally, our call centers at SSRS pivoted over the course of a weekend to stay-at-home functionality. So all of our telephone interviewing continued from at-home interviewers without interruption, essentially. So we were able to maintain the steady flow of data collection throughout the entire year as planned.
Thank you so much, Todd. And we are kind of out of time. I do want to ask one last question, but just want to let people know that if we did not get to your question, you can email us at healthpolicy@ucla.edu, and we will direct your question to someone on the CHIS team. We will be posting the recording of this online with closed captions within the next 2 weeks. So you can visit healthpolicy.ucla.edu/seminars for that. With sort of the last question and a close, if possible, can you share which of the CHIS results for 2020 you found either most interesting, surprising, or alarming?
Sure, I can start, then Todd can talk about some of the, not unexpected. We didn't really show this, but we were showing that, so for example, food insecurity decreased, right, during this time. And so, and yet hardships have gone up. What, in talking about this with some of my other colleagues, and particularly Mark Peterson from Luskin, is that, this was also being found in other surveys in other places. And it shows what the strength of a public safety net, public investments, all of the investments that were made in terms of, from the checks to several of the equity funds, that it did help Californians. It did go through this very, very difficult time. So it did show me the power of public investment, during a difficult time, and that we need to continue to do this to ensure that that Californians don't slip into further pain, particularly during a pandemic.
And I'll just add, not a surprising finding as Nina's was referring to, but for me, the most alarming finding we shared today was the mental health distress observed for those who experienced unfair treatment due to race. Those marked increases in suicide ideation, as well as severe psychological distress, really demonstrates the importance of addressing this unfair treatment due to race in our country.
Thank you so much, Todd and Inez and Sean. This was a great presentation. So also thank you to the audience for attending the 2020 California Health Interview Survey data release, and have a good rest of the day.